Thank you. Thanks for having me here. Uh, just to say a little bit more about what we do. I'm a healthcare IT consultant, work with the public sector as well as the private sector. Today I'll be basing most of my talk on the work that we've done with the public sector and a little bit touch upon what we are currently doing in the private sector in the e-health and the m-health space. Without wasting too much of time, I'll jump a couple of slides because I've been told I have precisely 7 minutes. And I will go directly to the work that we've done in the public sector. Now, this is a study that we've done with NHSRC, National Health System Resource Center. It was a joint study done with NHSRC in the public health IT space. Now, this report has been published. The report has been converted into an international paper and indexed on PubMed recently. What we did is we studied different healthcare IT systems at the national level, state level, and the RCH systems. I'll not go into the details of those. You can probably have a look at the slide deck if you want later. But what we found is pretty much similar to what the panel chair said, that most of these systems were in silos. They did not talk to each other. Each of the systems were created as an application, not as a product. And if you had to look at any data across these systems, it was impossible to do that. Technology was outdated. Capacity development was not done. So change management was not done. So what happened is adoption dropped after the initial spike. As a result, the usage of most of the systems is pretty low. And the data which is coming in different formats, so it's very difficult to make sense out of the data. They become data collection systems rather than decision helping systems. What do we do from here? How do we go to the next level? What we proposed to the national government is to have a national e-health authority. That's to answer the vision document that the panel chair had asked for. So we painted a vision document for the central government. We said you need to have a national e-health authority that lays down the architecture for all the IT systems that are out there. Now let's compare this to a town planner in a municipality or a town planner who does new planning for a town. What does the town planner do? The town planner basically lays down the standards for the roads, for the water inlets, for the sewer outlets, the common areas, and so on and so forth. But the town planner does not get into the floor planning of each building, each society, and so on and so forth. This is exactly what a National e-health authority needs to do. Lay down the standards for integrating all the different applications. As long as each application, each system is able to give the needed outputs and take the needed inputs from the others, it should be allowed to have its own architecture and flourish in its own way. Now, having said that, there is some challenges around that which need to be managed. So obviously, the National e-health authority needs to have teeth so that it can make sure that people don't fly off into a different direction. Now, how do you control that in a system like ours where healthcare is a state subject? What we proposed is that you should have the financing attached to the standards. Now, if they follow the standards, the financing continues. If they deviate from the standards, the financing is curtailed or removed, so that it becomes a deterrent for all the health systems out there to comply to the standards and remain within the system. However, some rich states are still free to go ahead and do what they want to, but largely we would be able to see a convergence over a period of time. Now, when we were doing this work, the Planning Commission actually got interested in what we were saying, and we got an opportunity to go and present it in the Planning Commission. Many of these things have been adopted as part of the 12th plan. If you look at the chapter 3 of the 12th plan, it has these recommendations in its place. Now, let's look at this a little more from an implementation perspective. Most of the states have a paper-based system. Now, this paper starts from the lower facilities, which is the sub-centers and the PHCs, and it gets converted into an electronic form only at the district level. Now, this is something which is perfectly fine as long as, the data which is coming from different systems can be collated into something called a health information exchange. Now, a health information exchange will have a facility registry, a service registry, and a disease registry, and a data warehouse, so that, you can do a slicing and dicing of the different data elements which are coming from the different systems. Let's go a little step further. There are states which are experimenting entry of data from mobile phones and from desktops right at the facility level in terms of PHCs and sub-centers. Wherever, like for example, Gujarat, they have connectivity available at PHC level, so they are experimenting in that way. Punjab and Kerala is experimenting mobile platforms to enter the data from the field workers. So those data elements again can be collated and put into a health information exchange. Now this is a patient-based data. So when it's a patient-based data, you need to have a patient registry, a UID-based patient registry. Now that is what we propose, that you need to have a UID, and the UID could be an Aadhaar UID. Until the Aadhaar becomes ubiquitous, you can use the local identifiers like the driving license and the voter's ID card, and some of the other local identifiers. And there is technology available called EMPI. EMPI is Enterprise Master Person Index. It can help figure out the different identifiers and actually say that with a reasonable degree of confidence that it looks to be similar, and then somebody can take a call whether these are different people or the same people or the same person. Now, you roll it up at the national level. What we proposed was that you need to have a national health information network. It is again a health information exchange at the national level, but at the national level, you don't need all the data. Let the states have the detailed data. The center needs to have only the indicators. So the indicators need to be defined up front. Roll up the indicators at the national level so that at the national level, things can be taken care of as far as the decision-making process is concerned. The reports are available, obviously, to all the different stakeholders, whether at the national level, at the state level, or even at the district level. Let me say a little bit what we are doing on the private sector. Well, on the public health side, this is what we were able to do. We were able to get it as part of the 12th plan. It's some of the things have been taken over there, but the implementation lies with the states because healthcare is a state subject. Now there is a reference point available. The states need to pick it up and run with it. Until that happens, we said, let's not wait. Let's do something on the private sector. What we have done is we tied up with private equity companies. We have tied up with some other technology companies. What we are doing is we are creating a platform where we are investing the money into technology, into providers, labs, and also bringing our advisory capability together with the standards so that we can drive the standards together with the funding which is taking place. I will not be able to give you too much of details on it because of the time lag, and we can take it offline. But this is what we are trying to do so that we can build what we have proposed, at least in the private sector. With that, I would like to stop here and say thanks.